In this podcast, we shall learn about supportive care for newborn on CPAP. The session shall cover the essential requirements for providing supportive care, how to provide ongoing assessment of the baby, and how to optimize the CPAP delivery. The essential requirement for caring for a newborn on CPAP includes adequacy of personnel, equipments, and monitors. The bedside care is provided by nurses and doctors. The nurse to patient ratio should be 1:1 ideally. The personnel should be well versed with airway anatomy, pulmonary physiology in newborns, must have basic knowledge of CPAP, possess skills for patient assessment, and have the ability to recognize and respond to adverse complications. The essential equipments required are similar to that used for stabilization of sick babies. These equipments include pulse oximeter, NIB monitor, suction source, suction catheters, orogastric tubes, resuscitation apparatus, portable X-ray, and access to ICD set. The third essential element for supportive care is bedside ongoing assessment. The goal is to monitor the trend over time. The clinical assessment will be instrumental in the success or failure for the newborn on CPAP. The clinical assessment has to be ongoing, systematic, thorough, and meticulous. Frequent assessment is the key. From clinical point of view, the assessment is directed to the neonate, to the CPAP interface, and to the CPAP delivery system. Remaining alert for changes in the infant status will allow for earlier interventions, increasing the success of CPAP and minimizing the risk of complications. Clinical assessment begins with the bedside observations. The purpose of general evaluation is to gain an overall impression of the condition of the baby based on visual and auditory clues without touching the baby. The purpose is to quickly identify if the baby is sick, well, or is there any danger sign. The general evaluation focuses on the appearance, work of breathing, and color. The appearance should give information as to how is the comfort level of the baby, is the baby crying, fighting, how is the tone, activity, posture, and movements. The breathing assessment includes the work of breathing and presence or absence of grunt. The color of baby, if pink, suggests stability. This is followed by assessment of the vitals. The vitals provide information about the cardiorespiratory stability, and the assessment should include temperature, heart rate, respiration, blood pressure, saturations, and urine output. This is followed by systemic examination. The circulatory status is judged by the heart rate, the peripheral pulses, the pulse volume, the capillary fill time, the blood pressure, urine output, sensorium, and the pulse oximetry. This helps us to define the normal or poor perfusion. None of these signs by themselves alone are diagnostic of shock, and one needs to take all of these into considerations. Fall in blood pressure is a late sign of shock. Presence of shock warrants search for an underlying cause. One must remember that if more than excessive CPAP is delivered, it may lead to poor perfusion. The CNS assessment includes assessment for sensorium, activity, tone, and responsiveness. Worsening sensorium should alert to underlying hypoxia. In the GI assessment, one should look for abdominal distension and the bowel sounds. Babies on CPAP must have an orogastric tube to vent off air. Quickly survey the CPAP settings to define is the baby getting the set FiO2, CPAP pressure, and the flow. The settings also guide you as to what the support the baby is receiving and what is the severity of underlying condition. No doubt the focus is on respiratory assessment. An objective way is to use the Silverman score. The score is essentially clinical and includes 5 parameters: the upper chest retractions, the lower chest retractions, xiphoid retractions, nasal flaring, and audible grunt. Based on the assessment, you grade the severity into grade 0, 1, and 2. The scoring is done at every assessment. Rather than one-time assessment, it is the trend in the score which is more informative. A score of 7 or more suggests respiratory failure. Clinically, assess the airway and the breath sounds. This is done by dividing the chest into the right and the left sides, and then dividing each side into upper, middle, and lower thirds. Auscultate and compare the differences between the right and the left side. Note the quality of breath sounds in each area. Compare with the baseline assessment to define is the distress same, improving, or worsening. The interface is the contact of the CPAP system with the infant's airway. Assessment should be made for the size, position, and appropriate fixation of the interface, as this is the key to prevent damage to the underlying tissues. At every opportunity, assess the nose, the nostrils, the nasal septum, and the adjoining skin over the face. Assess for color, perfusion, watch for blanching, redness, bleeding, crusting, possible areas of pressure or excoriation. If there is any blanching of the nares or the bridge is pressing against the septum, the prongs must be repositioned or changed to the appropriate size. The interface should be taken off every 3 to 4 hours during the process of suctioning of the nose, and the adjoining structures should be massaged to prevent congestion. The assessment for CPAP system should include checking for set temperature for humidifier, presence of condensate in the tubings, the water level, and the presence or absence of bubbling. Positioning of newborns of CPAP is an art. Nursing considerations should include how to position the newborn on CPAP and how to make things as comfortable as possible for the baby. The ideal position for a newborn on CPAP is that which promotes comfort and optimal airway. The prone position is often the preferred position, but there is no evidence in the literature that the prone position is superior. It is recommended that infants be repositioned at least every 2 to 4 hours. Repositioning is essential to the infant's neurodevelopmental and respiratory outcomes and allows for thorough assessment by the infant's caregivers. One should ensure avoiding excessive flexion, extension, or rotation of the head and neck. Newborns in any position need to be properly supported by rolls to form boundaries for containment, comfort, and ease. Once infants on airways are beyond the acute phase of RDS, they can be provided kangaroo care. Always ensure that the CPAP remains in the nares and does not become twisted during postural changes. Airway care for newborn on CPAP means ensuring that the airway is clear of secretions and the nasal septum is protected from damage. A baby on CPAP is likely to have increased production of mucus, which is a normal phenomena because of presence of prongs in the nostrils. The presence of excessive secretions will narrow the airway and increase the efforts of breathing. It may cause increased oxygen requirement, obstructive apnea, bradycardia, or maybe even pneumothorax. The newborns therefore frequently need to be suctioned to prevent narrowing of the airways and increased work of breathing. Universal precautions should be taken during suctioning. Suctioning is a delicate procedure and if done too roughly will cause mucosal damage, bleeding and/or swelling. While suctioning, moisten the nostrils with normal saline or sterile water to lubricate the catheter and loosen dry the secretions. Thickening of secretions indicate the need for increased inspired gas, humidity and/or heat. Always keep note of the color, consistency, and quantity of nasal secretions. There are no contraindications to feeding a newborn on CPAP once the baby is stable. The newborn on CPAP can be fed using bolus, continuous, or when stable oral feeds. An orogastric tube should be placed. Due to oral secretions, the orogastric tube is prone to slipping. The position should be monitored carefully and adjusted as necessary on a regular basis. The tube should be aspirated to remove air every 4 to 6 hourly, as abdominal distension can impact on lung volume and the work of breathing. Providing adequate nutrition should be a priority. Start early feeds. Trophic feeds or minimal enteral nutrition should be practiced till the newborn's condition is stable. Then the feeding can be increased as per standard protocol. If the condition is likely to be not stable over next 72 hours, parenteral nutrition should be planned. Daily order for fluids should have calculations for energy intake. Some babies on CPAP develop abdominal distension, what's called as CPAP Belly. This is due to accumulation of air in the stomach and should not be a reason for withholding feeds. To prevent such a happening, an orogastric tube should be left in situ with its end open to prevent gastric distension of stomach. This condition is essentially benign. Signs of improvement for baby on CPAP include comfortable baby, minimal or no chest retractions, normal capillary fill time and blood pressure and pulse oximeter readings in the normal range. Signs of worsening distress signal the need to reevaluate the infant's clinical condition and the level of support provided. Portable X-ray is useful for baby on CPAP. An X-ray is needed at 3 stages. Initially to confirm the diagnosis, to look for adequacy of CPAP pressure, and to confirm air leaks in case of acute deterioration. At least one chest X-ray would be required initially for establishing the diagnosis. Presence of visible rib spaces of 6 to 8 suggests adequacy of CPAP pressure. Ideally, blood gases should be done, but most babies with mild to moderate disease can be managed without it, but a pulse oximeter is must and mandatory. If baby has good respiratory efforts and normal blood pressure and capillary refill time, one may presume that the PCO2 and pH are normal. High CO2 in spontaneously breathing neonates with mild to moderate distress would occur either because of poor respiratory efforts or with an underlying air leak, both of which can be diagnosed clinically. Fluids should be administered as per standard protocol for preterm babies. Ensure adequate hydration, avoiding over or under hydration. There is no role to routinely restrict fluids. Monitor the urine output, as presence of diuresis in RDS precedes clinical recovery. Fluid therapy is titrated as per the clinical condition of the baby, the weight of the baby, the urine output, electrolytes, and urine specific gravity. Iatrogenic blood loss due to sampling is a cause of concern. Maintain a chart to record the amount of blood volume withdrawn for tests. Use minimal required blood for lab tests. Restrict tests to minimum required. Ensure that the hematocrit is kept above 40% during the acute phase. Follow stringent criteria for blood transfusion. For optimizing the outcome, developmentally supportive care needs to be supported and practiced. Simple measures include swaddling, containment, promotion of day-night cycle by lightening, minimizing sound levels in the NICU, and encouraging the mother to participate in caring for the baby. The infection control measures include simple strategies: hand washing, minimal pricks to the baby, early feeding with human milk, reducing the duration of IV fluids, IV access, lines, tubes, and catheters, objective measures to document infection, and early extubation. Disposable nasal CPAP kits are recommended and are intended for single patient use. The circuits need to be changed every 5 to 7 days. Following therapies have no role for managing a baby on CPAP: chest physiotherapy, steroids, diuretics, sotabacarb, sedation, and/or paralyzing agents. Every baby should have a CPAP monitoring chart which provides inputs on the care being provided to the baby every 2 hourly. The supportive care thus is ongoing systematic clinical assessment of the baby, the CPAP interface, and the CPAP delivery system. Special focus is given to the positioning of the baby, the airway care, nutritional support, and infection control. Every week, look at the overview of care being provided, the problems encountered, re-evaluate the investigation reports, and track the growth and nutrition of the baby to ensure comprehensive care. Thus, the supportive care for newborn on CPAP is a combination of dedicated teamwork, meticulous monitoring, and a humane approach. This shall ensure you would have more and more babies with better and good outcomes while being supported on CPAP.